I'm Dr. Laura Janssens, and I'm going to talk about ADHD. I'm going to talk about it in terms of my neuropsychology training. I'm going to talk about it in terms of some of the research that my mentor performed to understand this. He's written a couple books on the topic and several articles. I'll keep it simple in terms of introduction, and then we're going to break it apart in terms of a deeper dive to understand some of the more complex things involved with ADHD. The first thing to bring up is kind of this open question, like, what is ADHD? We have social media, and that's taken the concept and ran it down the field. You know, my intention as a trained neuropsychologist is to put some science and understanding behind this concept of ADHD. As a neuropsychologist, I do testing, and so there's objective measures, performance measures that help us understand this concept from an objective, a scientific, and a neuroanatomical way, in terms of the brain structure and what it's doing. Before I became a neuropsychologist, I was a psychologist, a clinical psychologist. And in some ways, these descriptions, these labels are a little bit different. So psychology, in terms of my earlier part of my career, was more about kind of the stereotype, but kind of lay on the couch and tell me about your childhood kind of psychology, the talk therapy, the challenging cognitive distortions, the support, all of those things. And so as a psychologist back then, it was more about personality testing and understanding theoretical concepts in terms of how your thoughts affect mood, how your family dynamics, your upbringing, the environmental factors that affect mood and functioning. And so that was a large part of the psychology training I had, and then a large part of the work I did earlier as a psychologist. I also did testing, but again, it was more personality based, doing objective measures in terms of questionnaires and inventories that asked about mood, projective testing in terms of like the older stuff like the Rorschachs and things like that. So there's ways of getting at personality. And again, they were pretty subjective, objective testing in terms of some of these questionnaires and inventories that were objective because of the way the tests are built, but really you're asking the person, how do you feel? You're looking at patterns of their responses against other populations known to have these conditions. And so in a large part, so psychology, more external based, more personality based, more subjective, and yes, there's objectivity in there as well. But so earlier psychology, then I kind of evolved into doing neuropsychology. I got involved with Len Koziel. You're going to hear me mention his name quite a bit. Dr. Len Koziel. He did neuropsych testing and taught classes in advanced neuropsychology, and a lot of these concepts are actually his, and I'm kind of carrying on his ideas in terms of sharing these things with you to advance your careers and your understanding. So a big concept here is this DSM, Diagnostic Statistical Manual of the Psychiatry. And so it's a manual, thick manual, that has listed every diagnosis that psychiatrists use. Insurance companies use those codes to reimburse. And it's a manual, kind of a dictionary, so to speak, in terms of what the labels are and what symptoms comprise these labels. And so almost exclusively, and there's exceptions in there, but it's subjective. Like you're asking someone, a professional is asking someone, a psychiatrist, a psychologist is asking someone, hey, how do you feel? Or what's going on, what brings you in, what's not going well, and how can we help? And so a person will describe their symptoms, a professional will observe the symptoms, and then based on listening, based on understanding the professional history of listening, the clinician's skills in terms of listening to the symptoms, then the clinician makes a diagnosis, right? And then listening to those symptoms, you look up in the manual and go, oh, okay, 314.01, that's ADHD, we're done, and let's see what we do from here, whether it's medication or leave it alone or whatever other things, behavior modifications to address it. But for the large part, ADHD is diagnosed by the behavior symptoms that are reported subjectively. And here's kind of a tricky thing that we don't talk about out loud. But when you go in that diagnostic manual, we're just talking about ADHD for a second, you look through there, there's really nothing, almost practically nothing in there that's objective. Behavior observation and checklist, yeah, is he getting out of his seat? Is he talking out of turn? Is he staring out the window? Is he distracted by external things? So, you can measure those. I mean, you could probably say that's kind of objective, but the person doing the measuring, who is that? Are we asking mom? Are we asking the teachers? Are we asking grandma, the neighbor, the mailman? Who is making these judgments? Are we asking a professional, et cetera? So for the most part, that's how ADHD is diagnosed, because it's defined that way. It's defined in terms of subjective behavioral observation. So you go in the diagnostic manual, it's mostly that. There's nothing in there about neuropsychology. There's nothing in there about testing and having a performance measure someone's attention. We're not asking, in a subjective way compared to your peers, how often do you pay attention, if that's what we're talking about in terms of definition, which we're not yet. But whatever, just on a basic understanding, there's not a measure of attention objectively in terms of performance evaluation in the diagnostic manual. So we're not diagnosing based on testing, we're diagnosing, again, based on behavior checklist. And that's all that's required, by the way. So if you have the number of symptoms on the checklist, you have a diagnosis. And you have to have a clinician kind of agree that you're not exaggerating or that you're not malingering. And that's tough to do. And just kind of off on a side road here, that research-wise, a third of the people malinger ADHD, and it could be more now with social media being more popular, but yeah, malingering. So what does that mean? Like you can look up Google, do it right now. I'm sure you've already done it, and you've already memorized the symptoms, and you can go into a doctor and say, I have these 6 or 8 things, and they will possibly prescribe medication. And again, a third of the people going in for help for this are malingering. Making it up makes it sound a little too malicious, but to the point of, what's objective here. And so basically DSM-5, which is our 5TR, our current list of diagnosis, our current list of understanding of what's involved in these diagnoses, has little or no neuropsychological evidence needed to make the diagnosis. So that's kind of interesting. The other thing, again, getting away from, what do we have to diagnose with versus what we do have and we're not using. We don't have any neuropsych testing in the DSM, and we don't have any neuroanatomical basis for understanding what ADHD. You look in that manual, there's nothing about the brain. Psychiatry doesn't need to know tons and tons about how the brain works. They, again, are looking at, subjective behavior. And by looking at behavior, you can understand the brain. So there's a connection. So it's not a complete, absence of this concept. But in terms of, understanding brain structure, neuroanatomy, what's going on in the brain, how things are connected, what parts of the brain do what, and what's involved in ADHD in terms of brain functioning, nothing's in there. So no testing and no biological understanding of this diagnosis, ADHD. And now I'm going to get a little into the historical or traditional way of looking at the brain in terms of how it's involved in ADHD. If you ask an average clinician, or the average person might know that, what part of the brain's involved in ADHD, they may well answer the frontal lobe. Okay, and you know what, to a degree that's correct. The frontal lobe is involved in ADHD. And that's how I was trained in my basic psychology training, that you memorize the brain, you have the brain pictures, you memorize the labels, and there's so much involved, of course. It's such a complex thing to try to learn, that you learn in chunks or categories or basic things. So there's a lot to memorize. So you associate frontal lobe with decision making, you associate occipital lobe with vision, you associate different parts with different things, and that's how you memorize stuff, and that's fine. And I'll say it's fine to get started, but in reality, what is missing in even the basic understanding of neuroanatomy and brain is the fact that the lesion model, we call it, is no longer good enough in terms of understanding how the brain works. And what's the lesion model? So prior to having a lot of neuroimaging capabilities as we do these days. There's fMRI, MRIs, CAT scans, all these things to take images, and they're not perfect either, by the way. They're very kind of blunt ways of taking images. Functional MRIs are getting there, kind of thing. QEEGs are getting there, troubles validity and all sorts of things in terms of imaging. But the point being is that before we had all of this advanced imaging capabilities, we were relying on figuring out what the brain's doing by looking at people after the fact, after they've had a brain injury. So if someone hit the front of their head, they suddenly look like they're impulsive, they suddenly look angry, they suddenly look like someone we talk about these days who has ADHD, trouble with organization, trouble with starting things, stopping things, executing decisions, planning, etc. And then as a result of, here's Mr. Smith who had a head injury, hit the front of his head, that must mean that the front of the head is involved in ADHD or executive functioning, and that's the end of that understanding. Then we go to Mr. Anderson, who was, we'll say, hit on the side of the head, and now their memory is affected, or learning. And then we associate the fact that, temporal lobe involved in memory. And so it kind of goes on that way, that we kind of map the brain out based on these lesion studies. And while back in the day that was probably, the best we had, and, good that we had that at least, but these days, again, we have more advanced imagery and functional MRIs to see the function of the brain. So the outcome of these more advanced ways of looking at the brain is that we now realize that the brain operates in circuits and networks. So the frontal lobe is certainly involved, but hey, you know what? The frontal lobe is connected to the cerebellum. Frontal lobe is connected to the thalamus, the frontal lobe is connected to the limbic system, the motor system, and we can go on that these are loops, right? So there's circuits and loops, so it's not so simple to say, hey, frontal lobe is executive functioning. You could very well have an injury to your cerebellum, which affects your executive functioning, and that is something that has been traditionally missed in our education. And again, not purposefully or maliciously at all, that's not what I'm saying, as much as we can only understand as much as we have available with technology, and to know that much, or even not even just the technology availability, but the resources in terms of going to school. So you have a psychologist who's trained in psychology, they have a doctorate degree, which is fantastic. They take one or two courses, probably one, maybe two. In neuropsychology, they might do an internship if they choose to, and that is, the training of neuropsychology, and the rest of it's in the field and working with mentors and professionals and reading and all of this stuff on the side that you do, and that's all fantastic. But again, you got to start somewhere, and so the cursory understanding of neuroanatomy is kind of in this lesion model, and it requires advanced learning, advanced understanding of the networks and the circuitry, and not just knowing what part of the brain's doing what, but what circuit is attached to, or what parts of the brain are attached to each other, and what does that mean. So in terms of kind of what I want to do here is kind of go beyond the basic understanding in terms of diagnostic manuals, which is to me very basic, and then go beyond this lesion model, which again is it's a means for communication, it's a means for understanding. It's not wrong per se as much as it's kind of scratching the surface in some ways in terms of understanding what ADHD is. And again, I want to get into the fact that ADHD and basic brain functioning has loops and connections, so it's understanding what these networks that are involved. I'm just going to name the loops. They're not going to make any sense until I deep dive into them, but just to give you a sense, hey, there's a lot going on here that's not being talked about with ADHD. There's a cerebrocortical loop, cortical basal ganglia loop, cerebrocerebellar loop, and basal ganglia cerebellar circuits. Okay, so these are loops in terms of large-scale brain networks. We have frontal parietal network, ventral attention network, dorsal attention network, visual network, limbic network, sensory motor network, and default mode network. So we're talking about loops, circuits, we're talking about networks. If you're not familiar with those, I wouldn't be surprised unless you're a deep reader and are following the research. Although, 7 brain networks, this was something talked about in 2011, so this is not new information, it's just advanced information, which can be difficult to grasp. And again, that's kind of what I'm here for, is to kind of bridge that gap with, okay, you've come this far in your training, your understanding, and this is to kind of take you to the next level. As far as, we'll get to those networks and circuits, but in terms of ADHD symptoms, again, the punchline here, it's not only a frontal lobe disorder. We need to understand in terms of neural interactions, in terms of starting to get into this objective factor of ADHD. It has to do with response inhibition. And I'm going to talk about in a little while studies by Stevens that were done in 2007, 2009, that talk about the different circuits that are engaged during a continuous performance testing, which I'll explain. But there's different circuits involved when you're selecting your attention on one thing and while you're unable to deselect information that's not important. So we'll get into a deeper dive on definitions here, but there's an objective machine that we use to measure, can you select attention? Because that's what you're doing. It's an active thing. I'm going to choose to look at my glasses down here. All the while not choosing in ways to not attend to other things that are in the room. So just doing one thing while not keeping the brakes on everything else. And so there's research studies that talks about the different networks. One network's doing the select and one network's doing the inhibition, and we'll go into detail about that later. Overall, kind of what I'm talking about is kind of understanding ADHD at a deeper level, being able to have objective ways of measuring it. Key point here is that 1/3 of the population, even children, by the way, I'm not just talking about adults or college kids or whatever, 1/3 of the people are misdiagnosed in terms of coming in and knowing the script, coming in and saying, hey, I have these symptoms, they memorize them on the internet, and or not even in a sneaky kind of way like that, or malicious per se way, as much as they are trying to label themselves based on some of these common characteristics that they think they have. And again, it's not kind of degrading anybody as they're trying to figure themselves out, as much as are they completely aware of the function of their own brain and what these symptoms look like. And what's the point? It's they have the proper diagnosis. It helps with validation and identity and understanding kind of strengths and weaknesses in yourself. That's all important to have diagnosis to a degree. And there's negative sides, and we can talk about that later. But these symptoms that we're talking about that are measured objectively are the ones that are addressed with psychostimulant medication. So the Stevens research that I'll get into talks about these networks that are involved, and if you have dysfunction in these networks, then that is evidence, test evidence, concrete performance evidence of a disturbance in the inhibition and attention selection network. And again, multiple brain areas involved. There's a dysfunction there that is known in research to respond to psychostimulant medication. And so don't we want to know that? Like, don't we want to know, do I have that objective symptom or don't I? ADHD is so commonplace to talk about, and whether people officially have it or don't, they may want to know for sure. And how do you do that? You have your testing and see if this objective symptom is showing up. And not only that, and this is going off the topic a minute, but what else could it be? Like, okay, you feel you have ADHD, but there's many other things that could be going on. It's not the only diagnosis in the world to help you understand your brain functioning and what you can do about it, because that's ultimately what you're trying to figure out. What do we do about this? You diagnose this, you get the proper treatment, and then you figure out what you do. And again, neuropsych testing is more than just measuring attention. We're measuring memory or mood, personality things, as a psychologist would, and looking at kind of the bigger scope, the bigger picture in terms of what is your development, right? So, by the way, ADHD is a developmental disorder. It's not something that turns up at age 50 or 40 or 20. It's something that has a trend in childhood. It may not have peaked in childhood for different reasons. It may peak, under certain challenges as a grown-up, but largely we're talking about a dysfunction in the brain circuitry. And again, yes, can an injury cause that? Of course. But really, when we're talking about common garden variety ADHD, it's developmental in nature, could be related to basal ganglia anomalies for different reasons in early development, and not going too far off. But point being, there's a physical basis for this ADHD by even DSM, diagnostic manual definition, is developmental. We're looking for it, prior to, used to be prior to age 11, prior to age 7, young childhood, we're looking for younger childhood, we're looking for these symptoms, and they just kind of turn up out of, so to speak, nowhere. So that's kind of my opening chat on kind of, starting to look into ADHD, understanding it in a deeper way in terms of, going beyond, DSM is a kind of a basic, categorization, understanding basic symptoms, fine. We have some neuropsychology 101, so to speak, where you understand lesions, studies, and parts of the brain. But then we get into this more advanced talk, we're really talking about circuitry, brain loops, and what does that mean in terms of objective testing, and then of course figure out what you do about that. So okay, that's all I'm doing right now, and I'll see you in the next video.